First of all, thank you for the invitation to share our recent findings at this time. Traumatic brain injury, TBI, is an injury by external force to the head, leading to disruptions in brain structure and function. And TBI is a substantial threat to public health in the United States. Depending on patterns of injury, TBI can cause cognitive difficulties, comorbid psychiatric symptoms, and late-stage complication among injured people. And depression is the most common psychiatric condition in TBI. And depression and TBI can negatively affect the level of cognitive functioning, quality of life, social activity, and recovery from injury. And from the clinical perspective, depression and TBI can induce same symptoms. So if we only focus on symptoms, it is hard to tease apart depression from TBI. And previous studies on treatment for depression and TBI demonstrated the efficacy of supportive psychotherapy, which induced social interactions with instructors, and cognitive behavioral therapy. And those studies demonstrate that the efficacy of both treatment options were comparable. Although these previous studies demonstrated the phenomenon, but it's not still unclear how that happened. And we are not sure how depression after the treatment, reduced depression, can be translated into improvement in other domains of functioning, and also underlying neuromechanisms is not clear. In previous study, we demonstrated the efficacy and neuroplasticity of cognitive training for chronic TBI. We administered two types of cognitive training. One is a SMART, Strategic Memory Advanced Reasoning training that focuses on improving cognitive control. The other training is Brain Health Workshop that provides information about brain structure and function, which involves learning and memory component of cognitive function. And both programs, provide induced social interactions in small group settings. And the goals of this study was to first identify whether small group-based cognitive training reduces depressive symptoms in TBI as a secondary effect. And the second goal was to examine the patterns of neuropsychological and neurocorrelates of reduced depressive symptoms. 79 individuals with chronic TBI participated in this study. Based on a back depression inventory, we subdivided the participants into two groups, one with TBI plus mild to severe depressive symptoms and TBI only. And both these participants underwent either one of the two training programs. And we acquired neuropsychological measures that are sensitive to depression and cortical thickness and resting state functional connectivity at 3 time points: before training, right after training, and 3 months after. In longitudinal data analysis, we performed the linear mixed effect model to look at group by time interaction of BDI scores. And for the correlations with BDI scores and other measures, we included between subject and within subject covariates for total BDI scores in LME, while a control for a training-specific effect. Since we are interested in how changing BDI scores over time can be associated with changes in other measures, we only focused on within subject effect of this model. For the resting state functional connectivity, we obtained the seeds from cortical thickness data, and the depression is heterogeneous in terms of symptoms, and also connectivity was specific to the subtypes of depressive symptoms. We obtained the correlations according to Berkeley cognitive, affective, somatic factors. Here, cognitive factors is related to negative self-perception, not cognitive function per se. For the results, group with depressive symptoms had a moderate level of depressive symptoms at the baseline, and they reduced their depressive symptom at the lower end of mild level of depression at 3rd time points. And these reductions only occurred in depressive symptom group, and these reductions were independent of types of training. And within the depressive symptom groups, at third time points, about 56% of these individuals showed release of depressive symptoms. And these patterns of reductions were independent of training types. For the correlation with neuropsychological measures, we identified the change in BDI scores were associated with changes in PTSD-related symptoms and self-perceived TBI-related symptoms and functional status. And this scatter plot at the group level clearly demonstrates the strong association between changes in BDI scores and functional status, which is negative association here. And those patterns only occurred with a depressive symptom group. For the cortical thickness analysis, we have identified negative association between BDI score changes and cortical thickness changes. Here, negative association means when the participants showed reductions in their BDI scores, their cortex became thickened after training. And those patterns only occurred with depressive symptoms group. For the connectivity analysis, we observed positive association between changes in BDI scores and changes in connectivity at each of the 4 seeds we obtained from connectivity data. And Berkeley factor analysis revealed that only cognitive factors showed association between changes in functional connectivity only within depressive symptoms group. And these patterns of association with cognitive factors were more prominent than patterns of association with total BDI scores. And this might indicate that reductions in cognitive factors of depressive symptoms may primarily lead to the association patterns with change in connectivity and change in total BDI scores. In summary, cognitive training for TBI reduced depressive symptoms, and those reductions in depressive symptoms were independent of training programs. And reductions in depressive symptom severity were associated with improvement in PTSD-related symptoms and self-perceived TBI-related symptoms and functional status, which is daily functioning level. And this change in BDI scores were also associated with increased cortical thickness and reduced resting state functional connectivity. And Berkeley factor analysis revealed that only a cognitive factor was associated with changes in resting state functional connectivity. Again, cognitive factors is related to negative self-perception. Thus, cortical thickness and resting state functional connectivity may be sensory biomarkers for evaluating reductions in depressive symptoms severity following cognitive training for TBI. And thank you for attention. And my poster is Wednesday and Thursday at this number. I'm happy to talk more detail if you're interested at this time. Thank you for your attention again.
We have time for some questions. If anyone has any questions. I thought it was interesting that an interesting talk overall, and then that the training programs didn't differ, even though what they consisted of was fairly different. What do you think it was that was common between them that led to the shared improvement, or do you have any thoughts on that?
Yeah, I thought of three factors. By the way, these patterns, the reductions in depressive symptoms, they're independent of training program. That is consistent with other previous studies in treatment for depression in TBI. One of the reasons that happened maybe social interaction in small group setting. That's one factor. Individuals with TBI, they live in isolated fashion. So they often live isolated fashion. Then during the training, they interact with other individuals with TBI and social instructors, and that may be one factor that shows reductions in TBI symptoms. And also, we see the correlation pattern that showed their daily life functioning level was improved at the training. Probably less frustration from their the difficulties in cognitive domain may boost their release of depressive symptoms. That is one factor. The another factor is based on patterns of resting state cortical thickness, the patterns occurred with right prefrontal cortex, and also when you look at functional connectivity, we looked at change in connectivity primarily occurred prefrontal cortex and limbic cortex. Probably improved emotion regulation may be one factor that changed these depressive symptoms after training.
Great.
Thank you.
Any other questions?